Welcome, everybody. We can see all of you coming on. So we will just give it a minute or two for everyone to get on here. That is very good. We have got 160 people registered. Thank you, everyone. And we have only been out promoting this for a week. So that is really great. So we'll just wait for a few more people to jump on. Great. Let's get into it, and the team will continue to admitting you all in as we start. Welcome everyone. We are recording this so that you can go back and look, or you can share it with colleagues and others that should watch this. So welcome to Lunch with Team Medical. This is the first in a new series that we will be hosting. So it's short, half-hour webinars. And I'm Anne-Lone Dalhoff. I am the Marketing Director at Team Medical Supplies. And I will introduce our speakers shortly. But first, a few housekeeping parts while you're all settling in. First of all, your cameras and microphones are off through the whole thing. So please enjoy, eat your lunch. We can't see you, but keep listening. Second one, what to expect. We will have a short, very informative presentation by our speaker for the first half, and then we'll have the last 10 minutes with Q&A. What we want you to do right now, though, is find the chat box. And for those of you who haven't done it before, at the top, it's a little speech bubble. Find that chat box and open that panel, because we want you to interact, and we want you through the whole presentation to be putting in your questions. Our marketing team is sitting ready to answer your questions straight away. And what they'll do is they as well will skim and gather some topics that are coming up a lot, so that we can feed these into John when we open the Q&A later. So I hope that makes sense. Eat your lunch while you're eating, find the chat box and be ready to ask some questions about what's new with flu. So let me check if I had anything else I wanted to do. Yes, at the very end, we'll have a quick 3-question mini survey, and it will literally take you a minute. But we would love for you to take that minute before you run off. It will be on the screen, and it helps us get feedback, and it helps us get even better for next webinar and others that will participate in the future. And then just today, because it happens to be the 8th of March, I just want to say as well, it's International Women's Day. Well done to all the women around the world and diversity in general. And thanks to all the people in our team doing so much work every day. So I hope you have a good International Women's Day today. Now, let's get into it. What's new with flu? So we as Team Medical Supplies are specialists in vaccines. Guess how many? You can put this in the chat as well. How many doses do you think we delivered? Back in 2020, we delivered over 2 million doses. As well, we actually delivered 100% of the pre-season orders. And finally, the key thing is our cold chain, that we're absolutely leading in cold chain and making sure we get it to you safely. So some of the things that we're really passionate about, and we care about vaccines and making sure to minimize the effects of flu this year. One extra thing this year, for every dose purchased, we're giving 1 day of clean water to someone in need in the world. So if we get to 2 million again, that is 2 million days of clean water. So thank you in advance for that part as well. Now, today's webinar, the topic is what's new with flu? And I'm really excited to be introducing you to our speaker, Associate Professor John Litt. And I will read his bio while you see a few things that you need to see on screen while we're clicking as fast as we can to admit everyone in. John is a public health physician, has been associate professor in the discipline of general practice at Flinders University. In 2019, John was appointed as member of the Order of Australia for his significant service to preventive medicine as an influenza specialist. John has over 130 refereed publications and is on the Immunisation Coalition Scientific Advisory Committee. So we're very proud and very honored and really happy to be having John on this webinar today. So the next page will just be showing you what we're going through. John will share 3 things with us today. 1, what insights he has into flu in 2022. Choice this year with innovative cell-based technology, and finally calling us to action. So ready to stop sharing our slides, and John will actually put up his slides and we'll get ready for a fantastic presentation. So thanks, Angus, John. And then Angus will stop spotlighting me so that everyone can actually see you. So take it away, John. Thank you so much.
Okay. Thanks, Anne, Lone and team, for inviting me to speak and to be the inaugural speaker for this brief webinar. I accept it as a bit of a challenge. For me to only talk for 10 minutes is really unusual. Let me also add my congratulations to International Women's Day. I think a lot is happening in that sphere, and I think this was providing a real focus for some of those events. I'm going to just quickly take you through influenza, and some of this may be familiar to you, but I think it's really worth a reminder. So here's a quick snapshot on the morbidity associated with influenza. And if we think about the last 2 years, you'd wonder whether, what this is showing and what's actually happened actually add up. But to remind people, in the big picture, influenza is the largest vaccine preventable disease by far. You can see that coloured bar on the left-hand side of the screen. Pneumococcal comes a close second, and that little grey bar is all of those other things that largely affect children, which are very important and can be life-threatening. But in terms of the morbidity, influenza is the big ticket item. And this little pyramid gives you an idea of, in a typical flu season where you'll probably have 5% of the population get influenza, that you're going to have quite a lot of additional GP consultations, so they'll be seeing it's busy. We all know about the hospital ramping, and often respiratory illness is a major contributor to that, of which RSV and influenza contribute. And the deaths typically is around 2,500. Now, the numbers reported are often much smaller than that, but there's very good evidence that for every death where there is influenza written on the death certificate, sometimes something like 5 to 8-fold the number of deaths are actually you can attribute to influenza if you drill down, but people haven't always measured or assessed whether the person's had influenza or not. What's not on this slide is a term called catastrophic disability. And I think one of the things that's really important to mind in older people, just going into hospital has a big impact on their functional status. And there are some conditions that make it particularly worse. And 2 of those are influenza and pneumonia. So in a Canadian study where they looked at admissions over several flu seasons, something like 8% of people over the age of 65 who had influenza on their diagnosis admission died. A similar number had significant disability, and a similar number again had catastrophic disability, which is the total loss of ADLs in at least 2 areas. So it's something where not just the deaths are important, but the impact on functional decline, which is most seen in the older population. Now, this is what happened last year. If you have a look at the graph, the red bar trickling along the bottom is 2021. So we had a very, very low season. The little dashed green bar above that is the 2020 season. So the last 2 years, some things happen where we had very little flu. And we can actually speculate on that. If you ask Ian Barr, who was the originator of this slide, Ian puts number 1, international travel stopped. Influenza virus likes to travel, preferably business class, and when it travels, it can disperse influenza throughout the world. And clearly in the last 2 years, a lot of that has been disrupted. We've had border disruption in terms of border closures, and we've also had social distancing. But those sort of social distancing and the vaccination rate are not the main reason why we're not seeing much influenza. It's just that it hasn't been around because largely we've stopped it. So why do we need to do better? This is kind of an introduction to the enhanced flu vaccines, and I'll be talking about 2 of them. Here's kind of a snapshot by Sheena Sutherland. It was published several years ago of what has been the effectiveness of influenza vaccines in different seasons over the last sort of 5 or 6 years. And you can see that the average sits around 50%. And if we said that about something like a measles vaccine or the polio vaccine, we'd be very disappointed. And so there's lots of room for improvement. And there are various reasons why it's a challenge, partly because the virus both shifts and drifts each year. And so it's really hard to kind of match up what's circulating with what's about. And then there's a 6-month lead time from when the WHO do that to get the vaccine. So a number of the vaccine manufacturers are trying to do something about that. So let's have a look at what's been happening. So the first one is an enhanced adjuvant. And it's also, the first one is that they've actually shifted from growing the virus seeds in maiden Derby kidney cells, which are a mammalian cell culture. And the reason for doing that is that while eggs have been used for a very long period of time, the challenge of growing influenza in eggs is that the virus has to adapt to infect the chick embryo egg. And so that leads to a change in what the WHO has recommended. And so that means that what the WHO has said and what's actually available in the vaccine is slightly different. And if the WHO has matched the virus really well to the circulating strains, then you're going to have a problem. A kind of a simple analogy, if you're at a gun range and you're shooting a rifle, the first thing you do is adjust the gun sights to your vision. And so if that needs calibrating, if you're shooting accurately, then you'll hit the target. If you're shooting continually to the left, then that calibration needs to happen. So what the cell culture vaccine has done is it makes the calibration of the vaccine, the virus is grown exactly the same as what is recommended by the WHO. That has several of other advantages, but largely it eliminates the mismatch, and particularly when there's an H3 circulating, which is a significant strain because of the morbidity it causes, then you actually make sure that what you wanted is what you get. So that, as I said, makes it really clear. The other thing that actually, I've covered all that. Moving on to the next slide there, it's a very safe vaccine. It has some other advantages. It actually speeds up the manufacturing process. It eliminates the need for some of the preservatives and excipients, so you can be confident that people are getting a vaccine that doesn't have things that they're worried about. And we've known in the past that things like aluminium or mercury in vaccines have been a concern. So that deals with it. This slide focuses particularly on the safety profile. The kind of pictorial slides on the right-hand side of the slide are relatively small, but I can summarise them fairly succinctly. Largely, more than 100 million doses of this Fluzone quad has been distributed, and there are no serious safety issues. It's shown that the profile is very similar to the egg-based one there. There is a slight increase in local pain and redness, and from a systemic symptom point of view, a slightly higher incidence of headache and fatigue. And in children, you might see an increased incidence of irritability, but it hasn't affected the uptake of the vaccine, and it's been tolerated and is regarded as extremely safe. It's indicated for children above the age of 2 and all adults. Clearly, in the older age group, we offer, in those over 65, the enhanced flu vaccine, and I'll get on to talk about that shortly, but largely we have two options, one which is funded on the National Immunisation Program. So the second flu vaccine that's emerged, which is available this year, is the Fluzone Highdose vaccine. So it's, again, a quadrivalent vaccine, and Sanofi has taken a different approach to enhance this vaccine by actually putting 4 times the dose of each of the antigens. So there are 4 different strains in the vaccine each year. There are 2 B strains and there are 2 A strains, normally an H1 and an H3. And so you have 4 times the antigen dose, which actually turbocharges the impact of that. And that has now been recommended by ATAGI to be available for people over the age of 60. But significantly at the moment, it's not on the National Immunisation Program, so people are going to have to pay for that. And ATAGI have made it really clear that they don't see any difference between either Fluad Quad, which is the Seqirus product, or Fluzone Highdose equivalent, which is the Sanofi product. The review on the right comes from a recent systematic review, which is giving us some indication of the effectiveness of the high-dose flu vaccine. And you can see that you're getting at least, and this is relative effectiveness, this is not absolute effectiveness. So this effectiveness highlighted in the red box there is the additional absolute benefit you get over a standard dose vaccine where you're using a regular dose of antigen. And so the impact on influenza-like illnesses is a 15% improvement. There's about a 12% improvement in hospitalisations. The particular benefit you can see halfway down the thing there is pneumonia and influenza mortality. There's something like a 40% improvement. So it's the pattern with vaccines is it may prevent infection, but its main role is to prevent serious disease and complications. And so it's interesting that the high-dose flu vaccine has got some good data about that. In my discussions with Sanofi recently, there are no immediate plans to put that on the national immunisation program. That might come hopefully in the future. This is a grade review looking at its safety profile. And so you can see in the grade column, that's the high-dose vaccine. And so you can see the influenza effective, they found at about 24% improvement over the standard dose vaccine. There is an increase in the combined local events like local redness and swelling. So that's up to by 30 to 40%. That's the relative risk of 1.4. The impact of pain is similar. And then in terms of the other symptoms, there's less confidence in those estimates, but really just saying that you're going to have a bit higher reaction. And my explanation is if you've got more antigen in there, it's going to irritate more. And a lot of us clinicians would say to people, which is not strictly immunologically correct, but if you have more of a local reaction, then we know it's working. But clearly there's evidence to show that there is good benefit from this vaccine. So we've got these two new vaccines. How do we actually improve things? This is straight from the ATAGI statement, and the link there is down below. And largely they're making it really clear that everybody ought to be getting influenza vaccine. It's not necessarily funded. We clearly need to put it on the immunisation register so that so it's recorded so we can actually get some idea about coverage. And while there hasn't been much flu around, it's really clear from people like Ian Barr that once you open the borders, we're going to see a lot more flu about, and it will be a problem. So we can give flu vaccines with any of the COVID vaccines using the opposite arm. If we're giving it to over 65, Fluad is recommended over the standard flu vaccine, but there's no preference for either Fluad Quad or the Fluzone, except the issue obviously is that Fluad Quad is on the National Immunisation Program and so it's free for those over 65. For those over 60, they might get some cover with their health insurance, but it's not on the National Immunisation Program. And even if you had one in the previous year, you should be getting a flu vaccine this year. There's good evidence to show that regular flu vaccines have a benefit. They kind of spread the profile and provide a broader spectrum of risk. That said, we typically see protection maximal in the first 3 or 4 months after vaccination. And so that may well influence the timing of giving it. If you give the flu vaccine in March and then we have flu in August, then a lot of people are going to be more at risk. There's mixed views about a booster shot, but the evidence is really thin to say whether you should add in a booster shot. The table there, which is relatively small, is really just highlighting from the National Immunisation Program who actually is eligible to get that. And so the usual chronic disease culprits and then people are immunosuppressed, so that all of those will be familiar to you. So we need to improve vaccination for a number of reasons. We know there's good evidence against vulnerable populations and it is cost effective. It's probably the most cost effective thing you can do in the elderly population. It has a bigger impact against severe influenza and its complications. It reduces hospitalisation and cardiorespiratory events. Just to sort of highlight the complications, influenza increases the person's risk of both a heart attack and stroke, and that is actually reduced by people getting a flu shot. So that's another reason. Because the virus shifts each year, and in an epidemic, or when we have a pandemic, there's a major shift, and so we have everybody vulnerable, and everybody's now an epidemiologist and understands that with respect to COVID, but it means we actually need to get it annually. And as I mentioned earlier, repeated levels of vaccination offer higher levels of protection. The other thing just to be mindful, which is not on this slide because we're not going to spend much time or not going to spend any time on COVID, is that there is the risk in a winter season of having both influenza and COVID at the same time, which has been dubbed flurona. And so in theory, because you've got 2 respiratory infections, you're going to be a whole lot worse off. That remains to be established with the evidence, but it's a good reason. If you've had the flu shot and then you're getting a sniffle or something else, that's more likely to be COVID than flu. And so if you don't have both vaccines, it's going to be hard to tell, and you're going to require a further level of testing. Just getting to the stage of finishing off here, this comes from the National Influenza and Pneumococcal Survey that I coordinated with colleagues over 20 years ago. We sampled 4,500 people in 200 practices around the country, and we kind of factored in everything that influenced people about their flu shot that we'd known at the time, and things haven't greatly changed. So this is an odds ratio after all of those other reasons have been adjusted. And at the top of the list, a recommendation from a GP or a practice nurse is the major influencer on people getting the flu shot. So that can be a very brief intervention. If your doctor suggests to you that you should get the flu shot, it's very likely you're going to get it. The only thing it doesn't tend to counter, it does counter, it counters adverse effects in terms of people's worry about that. It counters about whether the vaccine's working. But some people have this belief that getting the disease is better, or their own immune system can be boosted, and that doesn't work as well. The thing to really stand out is if people say they don't need it, that's a group that does need a further discussion. So in a nutshell, GP recommendation, people having regular flu, older people, and a belief in the vaccine makes a difference. So that's a very whirlwind 10 minutes.
Thank you so much, John. I know that was a Guinness record for you, packing so much information into 10 minutes. I really, really appreciate it. That QR code, please, everyone, while I'm wrapping up, if you can scan that one, because we would love your 1-minute feedback to this short webinar. And while you're getting that survey in and taking a minute, I'll just come back to some of the questions you got time to answer, John, because really at the end of the day, it is about getting vaccinated. That's what you had on your last slide. And at the end of the day, because I saw a question with what are the reasons people don't get it? And on that slide, people can go back in the recording and see, because there were some of the reasons, and how they link in. What is it people are worried about? So it really matters, that conversation we have, between patients, all of you on the call, nurses, doctors, etc., to understand everyone's needs. So with that, it's 1 o'clock, so I'll quickly go back one slide, if you wouldn't mind, Angus. And we want to say thank you, tak in Danish. That's my accent if you've been wondering what that is. Thank you so much, all of you, for spending your lunchtime with us and team. And thank you so much, John, for being our first speaker in these lunch with team. Thanks for doing the feedback on the questionnaire so we can learn and what we want to improve for next time. And then remember, for every doses this year, we're giving clean water for a person in need through the G1 Business for Good. So we're not just helping ourselves and those in our communities, but actually people around the world. So, and I can say that we have actually started, the team is getting so ready to start sending things out. So thanks everyone for being prepared, not scared, as our theme is this year. I think that's it. Please continue filling out your survey, and otherwise you'll get a thank you email from the team. You'll have the link where you can see the recorded webinar. You can ask more questions until Friday. So get in with all of your questions on the website link that you'll get in the email. And if you're interested in events, keep looking on our website. Next Tuesday evening, we have Be Brawn on The Scar is Your Signature. That's an evening one, so please keep an eye out there. Thanks, everyone. It is 1 minute past. I'm going to wrap up, and John will catch up soon. Thank you, everyone. Bye.